Good morning, sir. Good morning, everyone. Today, I am going to present a topic on evolution of the neck dissection. It's the most interesting topic. Yes, it is the most controversial topic. How the neck dissection has been evolved over the past 2 centuries. We will get to know by this presentation. As we all know, status of the cervical lymph nodes is the single most important prognostic factor in the treatment of the patient with squamous cell carcinoma of the head and neck. The 5-year survival rate for the early stage disease is up to and upwards over 80%. However, if there is a presence of nodal metastasis, the survival reduced by 50%, and along with it, if there are any extranodal extension present, the survival further reduced by another 50%. Also, there is an incidence of microscopic metastasis in a clinical negative neck as high as 25%, making the elective treatment of the cervical nodes as an integral part of the care for the patient with head and neck cancer. So, neck dissection forms an important surgical procedure for the management of the metastatic nodal disease in the neck. The neck dissection has been evolved over the last 2 decades, 2 centuries. The classical radical neck dissection remains the standard practice for the management of lymph node metastasis in the neck for nearly 3 quarters of the past century. However, the philosophy of the surgical management of the neck metastasis has changed considerably over the past few decades. With a better understanding of the patterns of the nodal spread, nodal level classification, improved anatomical and functional imaging, importance of the extracapsular spread, and better adjuvant therapies, the routine use of radical neck dissection has been replaced with a functional neck dissection, modified radical neck dissection, and selective neck dissection to preserve the vital structure in the neck and achieve better functional results. This is a slide which is showing the evolution of the neck dissection starting as back as 1880 by the Cocker, who was the first one who conceptualized the removal of the submandibular triangle neck dissection nodes in the tongue carcinoma patient. From there, the starts with Jordinsky, followed by Kreil, followed by Hayes Martin, Suarez, Boca, Lindbergh, and Shah, to the recent evolution of sentinel and lymph node biopsy, superselective neck dissection, and minimal neck dissection. We will go through each of them in brief in the coming slides. So, Sir Henry Tantrum Butlin, which is also known as the father of the British head and neck surgery, he in 1885 gave the concept of the elective neck dissection. He advised the removal of the cervical lymphatics through a Cocker's incision and suggested routine elective excision of this tissue in the treatment of the tongue cancer. Butlin's idea was the first breakthrough in the development of the effective treatment for the regional metastatic disease in the head and neck. He also reported a 3-year survival rate of 42% of his 70 patients where he did the neck dissection compared to the 29 patient in which only the tongue cancer was excised. So in his paper, he proved that the neck dissection improved the survival in oral cavity squamous cell carcinoma. Now comes the Jordinsky. In 1888, the Polish surgeon Jordinsky performed and reported an operation which compromised an extended radical en bloc resection. The patient was discharged soon after the surgery and the case was presented 6 weeks later in the Medical Society of Warsaw. The patient survived 7 years after this surgery, but Jordinsky never reported any similar operation, probably because of his premature death at the age of 45, and also the article was published in a Polish journal, so his work remained obscure. Now, the landmark article published in 1906 in JAMA by George W. Kreil of the Cleveland Clinic, USA. This landmark paper established the basis for the effective treatment of lesions by delineating a block resection of the cervical lymphatic bearing tissue to be removed either in continuity with the primary tumor or as a secondary operation for subsequent metastasis. In his 1906 series, only 36 of the 132 operations were radical en bloc dissection. The other 96 were more selective which is today called supraomoid neck dissection. At 3-year follow-up, the patient who underwent radical en bloc dissection had a better overall survival, 75% were alive, than those with a lesser operation in which the selective neck dissection were there, in which only 19% were alive. So he reported that radical block dissection had shown itself a 4 times more effective than the less radical surgical procedure. Cryle's en-bloc dissection involves the removal of all the cervical lymph nodes, which are today called level 1 to 5, along with the sternocleidomastoid muscle, submandibular salivary gland, tail of parotid, omoid muscle, cutaneous branches of the cervical plexus, and most importantly, the IJV. So it is a very radical neck dissection where, along with the lymphatics, the non-lymphatic structures were also removed. The concept and principle behind the Cryle en-bloc dissection came from the Halsted surgery, in which the radical mastectomy was done along with the removal of the axillary lymph nodes. Such radical surgery at that time was fraught with difficulty because of the lack of blood transfusion, antibiotic, and endotracheal anesthesia. But Cryle, through his expertise, devised several strategies for combating this obstacle, and he concluded that anything less than en bloc dissection was not effective in the control of the cervical lymph node metastasis. So this is the Kryle's landmark article in which the diagram he shows the multiple lymph nodes in the neck, followed which he did the radical en bloc dissection where he removed the muscles from the lower border of the clavicle from the mastoid tip, and along with that he has removed the internal jugular vein, spinal accessory nerve, omoid muscles, and everything. So coming to the Hayes Martin, he is the greatest impetus for the development of the radical neck dissection. He was a surgeon at the Memorial Sloan Hospital in New York who later popularized the radical neck dissection in 1951. He has reviewed his 1450 cases of neck dissection performed from 1928 to 1950 through the Martin's incision, which is shown in the left side of the diagram. It is a bitrifurcate incision extending from the angle of the mandible anteriorly to the mastoid tip superiorly and posteriorly, followed by the vertical incision and another Y incision in the supraclavicular region. Hayes Martin categorically insisted that spinal accessory nerve, internal jugular vein, and the sternocleidomastoid muscle should be removed in the presence of a cervical lymph node metastasis. And he emphasized that any technique that is designed to preserve the spinal accessory nerve should be condemned unequivocally. So he was a proponent of Cryle's radical neck dissection, and in his article he popularized radical neck dissection and gave step-by-step surgical procedure for the neck dissection. Coming to the Oswald Suarez, who is also known as the forgotten father of the functional neck dissection. The term functional neck dissection was first given by an Argentinian surgeon, Oswald Suarez, in his Spanish paper of 1963, where he discussed his experience of 803 functional neck dissection done on around 1300 patients of larynx and hypopharynx. In the American literature, Suarez functional neck dissection is often incorrectly mentioned as a Boca's neck dissection because it was Bocas and his co-workers who popularized the method in the English language. Boca was actually a fellow under Suarez, and he had a privilege of observing Suarez's work in the operation theater. Boca and his group in 1984 has presented a large series of 1500 functional neck dissection performed on 843 patients. So coming to the Boca's article, among the proponents of the non-radical neck dissection, the two Italian surgeons, Ettore Bocca and Oresto Pignataro, popularized the term the so-called conservative radical neck dissection or the functional neck dissection. In their landmark paper, this author provided the anatomical basis and clinical rationale for functional neck dissection, and they describe how the internal jugular vein, SCM, and spinal accessory nerve could be preserved, and yet the complete removal of the cervical lymph node can be ensured. Also, they have compared the oncological safety of the functional neck dissection that with the classical radical neck dissection, and they told it is a curative and there is a oncological safe procedure in clinically node negative cases. Coming to the another landmark paper by Jatin P. Shah from Memorial Sloan Kettering Center, he and his colleagues Lindbergh and all has developed the pattern of cervical lymph node metastasis from the squamous cell carcinoma of the upper aerodigestive tract. He, in his paper, gave the classification system of the cervical lymph node. It was divided into the 5 levels for the oral cavity. This classification system was very well accepted by the surgical peer group as it was simplified and easy to represent anatomical description of the lymph node. The level 1 consisted of the submental and submandibular group of lymph node. Level 2 is the upper jugular and posterior digastric group of lymph node. Level 3 is mid jugular. Level 4 is the lower jugular or supraclavicular, and level 5 is the posterior triangle group of lymph nodes. So he has done the retrospective review of the 500 patients with the primary oral cavity squamous cell carcinoma, among which the 295 patients were clinically N0, in which he performed elective neck dissection in 192 patients and subsequent therapeutic neck dissection in 103 patients. The patient with the clinically N plus, which were 20 and 6, the immediate therapeutic neck dissection was done in all of them. Coming to the result, the first table shows the subsite distribution of the oral cavity, in which the oral tongue and pure mouth constitute more than 60% of the cases, which is 36 and 33, followed by the gum, RMT, and cheek. Table 2 shows the distribution of the stage-wise distribution, in which the stage 2 and stage 3, the percentage of that group were higher as compared to the stage 1 and stage 4. The third table shows the prevalence of the nodal metastasis by the neck level. The most prevalent group of lymph node were the level 1 and 2, followed by level 3, followed by level 4, and rarely level 5 was metastatizing in the oral cavity squamous cell carcinoma. So he provided that in oral squamous cell carcinoma, the pattern of lymph node, the first echelon lymph node will be level 1 and 2, followed by level 3. In absence of level 2 and 3 negativity, it rarely metastasizes to level 4 and 5. So by this paper, the concept of selective neck dissection gained popularity. So these are the list of prominent personnel who has developed milestone in the evolution of the neck dissection. The before Kreil were the Theodor Billroth, von Langenbeck, Cockers, Jordinsky, Butley, and the grandfather of head and neck surgery, George Kreil. And after Kreil, the work has majorly done by the Hayes, Martin, Conley, Suarez, Boca, Lindbergh, Shah, and colleagues. So there were multiple terminology described in the literature: comprehensive radical neck dissection, functional neck dissection, selective neck dissection. So there was a no clear-cut guidelines and nomenclature. So with American Association of Otolaryngology and Head and Neck Surgery, Robbins published a classification of the neck dissection in which he described radical neck dissection as the resection of level 1 to 5 along with the SCM, spinal and IJV, with none of the structure were preserved, followed by the extended radical neck dissection in which the nodal removal from 1 to 5 along with the additional level of lymph nodes such as retropharyngeal, parapharyngeal, superior mediastinal, parotid, and additional structure excised such as hypoglossal nerve, vagus, or ECA. Then comes the modified neck dissection in which the level 1 to 5 were removed, but there are some of the structure which are non-lymphatic can be preserved such as SCM, IJV, and spinal accessory nerve. Then comes the selective group of lymph node in which one or more group of lymph node has been preserved. So this publication standardized the nomenclature of the neck dissection. Coming to the neck dissection type and indication, deciding what type of neck dissection to be done and when to do neck dissection, when to not to do neck dissection is a more complex problem today with many combination and possibilities, which requires careful planning, skill and judgment. So there are few controversies in the neck dissection, whether it has to be performed in continuity versus discontinuity. So this is the article from Italian group in which they retrospectively studied the discontinuation versus incontinuating neck dissection in carcinoma of the oral cavity. This was a retrospective analysis of the patient in which surgery was done between 1996 and 2001 for the floor of the mouth and oral tongue squamous cell carcinoma at Brazil and Milan, Italy. Overall, 193 patients were studied, and the authors found no statistically difference in disease-specific survival between both the groups. So, discontinuation neck dissection seems not to change the disease-free survival or disease-specific survival when compared to the in-continuity neck dissection. Coming to the another controversial topic, which is a neck dissection in a N0 neck, whether to do a neck dissection in N0 neck or not to do, and what should be the extent of the neck dissection in a clinically N0 neck. So this is a landmark article published by the Tata Memorial Group led by Dr. Anil D'Cruz, in which they did the study on elective versus therapeutic neck dissection in non-negative early oral cancer. This was a prospective randomized controlled trial from 2004 to 2014 in which 596 patients were enrolled. The analysis was done on the final 500 patients in which 245 patients were included in the elective surgery group and 255 in the therapeutic surgery group. At 3 years, the elective neck dissection results into improved rate of overall survival of 80% as compared to the therapeutic neck dissection, which is 67.5%. So, elective neck dissection has an 12.5% improved rate as compared to the therapeutic neck dissection. Also, it has a significance of higher rate of disease-free survival as compared to the therapeutic surgery group. So they concluded that elective neck dissection at the time of resection of the primary tumor confirms an overall survival benefit in patients with early stage clinically node-negative oral squamous cell carcinoma. This is the performance scheme of the trial in which the early N0 oral squamous cell carcinoma were randomized into the elective group versus wait and watch, and then therapeutic neck dissection was done and followed by the treatment. And second randomization, if they are wait and watch, what should be the criteria to do the, either it has to be a physical examination or they are done with physical examination plus sonographic neck and follow up. So this is an Kaplan-Meier and chart which shows the improved survival. The blue line is the elective surgery group and the red line is the therapeutic surgery group. So elective surgery group has a better overall survival in terms of both overall and disease-free survival. So coming to the another landmark article, a meta-analysis by Abu Ghanem and group, in which they compared an elective neck dissection versus observation in early stage squamous cell carcinoma of the oral tongue. They have included a 20 retrospective study and 3 prospective randomized trials and included an evaluation of more than 3,000 patients. And they showed that the elective neck dissection significantly reduces the risk of regional recurrence and improved disease-specific survival compared to the observation. This is a below chart which shows the forest plot in which the diamond curve is more towards the favor of END. They have evaluated all the retrospective studies and the 3 prospective studies. Another landmark article, which is a STAND study, which is done in the British and European group. And also this study has evaluated the survival benefit of elective neck dissection in early stage oral cavity carcinoma, including in the small tumors. So all these articles favors elective neck dissection in N0 patient as compared to the observation. So now one has to perform the elective neck dissection in N0 patient. What should be the extent of the neck dissection? Either it has to be a selective neck dissection or a modified radical neck dissection. So there are the Brazilian head and neck group studies which did evaluation of 148 patients in which 76 patients underwent modified neck dissection while 72 patients underwent supraomoid neck dissection. The recurrence and the survival rate were similar in both the groups, and they concluded that supraomoid neck dissection can be recommended as a standard elective treatment for patients with T2 to T4 oral squamous cell carcinoma with N0 status. Another article which presents a management of N0 neck in oral squamous cell carcinoma. They told elective treatment of the N0 neck is a complex decision because there is a no accurate way exists to determine the risk for focal metastasis. Also, the imaging and has been advanced with the advent of CT, MRI, PET CT, but the sensitivity and specificity of all these images technique is not 100% accurate. This lies in the range of 60 to 80%. So the surgical management of the N0 neck is ideally performed through a selective neck dissection of level 1 to 3, and SND is much less morbid than the radical neck dissection. Another controversial is whether to do the level 2B dissection and level 4 dissection. So coming to the skip metastasis concept given by Robert Myers in 1997, he defined skip metastasis as the presence of nodal metastasis distant from the primary tumor and at a lower level without metastasis at the level above this. So he did a retrospective study from 1970 to 1990 of 277 patients, and he found an overall frequency of skip metastasis as high as 15%, which also included recurrence, but the actual level 4 skip metastases were only 3 to 3.3% only. So this is another systemic review and meta-analysis which assess the rate of skip metastasis to level 4 in patient with clinically node negative N0 neck. So they included 11 retrospective study and 2 prospective randomized clinical trial from 1970 to 2017, and they found the rate of skip metastasis was extremely low, ranging from 0 to 5%, and they showed that skip metastasis to level 4 is very low. So another study by Tata Memorial Group led by Dr. Gauri Pantvedya, in which they prospectively studied 583 neck dissection patients, and they found that level 1 to 3 were involved in 91% of the cases. The overall incidence of level 2B involvement is 3.8%, level 4 is 4.7, and level 5 were only involved in around 3% of the cases. There was no isolated skip metastasis to level 4 and 5, as we can see in Dr. Jatin Shah's paper in 1990. The level 2A positivity was a predictor for level 2B and 5 metastasis. Metastasis to level 2B was 3.8% in tongue carcinoma and 6.2% in the RMT carcinoma. So as tumor goes more posteriorly, the posterior group of lymph node and lower level of lymph nodes are involved. Metastasis to level 5 was most often seen with buccal mucosa and lower alveolus carcinoma. So another article by Tata Memorial Group led by Pankaj Chaturvedi, in which they found the incidence and impact of the skip metastasis in the early oral carcinoma. This was a retrospective review from cases from 2016 to 2020. They found the occult metastasis rate of around 17.9% among 700 patients, with 47 traveling to level 1. Skip metastasis to level 3 was only 1.2%, and to level 4, which was less than 1%, which is 0.3. The 5-year disease-free survival was significantly reduced with isolated level 4 metastasis. So they concluded that negligible incidence of skip metastasis to level 4 in a clinically node negative neck suggests that clearance up to the level 3 might be adequate in large majority of the patients. So to be or not to be, that is the question. So doing a level 2 dissection and level 5 dissection hampers the functionality of the spinal accessory now. Most of the patient will have shoulder dysfunction. There will be winging of the scapula, drooping of the shoulder, and chronic pain. Also, if we not remove, if it is clinically involved, whether it is oncological safe or not, we'll see in the coming slides. So this is the Wien Palleri group, in which they did the prospective study and systemic review of the level 2 involvement in squamous cell carcinoma. They included 14 articles with 900 patients, and they found out that the overall incidence of metastasis to level 2B in a N0 neck from any subsite was around 2% only. The oral cavity has 3.9%, oropharyngeal has more 5%, and laryngeal cancer is only 4.4%. Isolated metastasis to level 2B was rare. Coming to another systemic review and meta-analysis of 22 studies with more than 2,000 patients, they found out that the 6% of the patient has level 2B metastasis and has a higher incidence in tongue carcinoma. Metastasis to level 2B is always along with the metastasis to level 2A. Only 3 patients were found to have isolated level 2B metastasis. This is another study which is a randomized control trial to assess the shoulder function after level 2B neck dissection, and they found out that those with aggressive level 2B dissection, there is a shoulder morbidity and functionality has been reduced as compared to the limited 2B dissection. And they concluded that level 2B should be omitted in a selective group when it is oncological safe and feasible. So when to do contralateral neck dissection? So this is an article by DeCruz, Sir et al. And team in which they did the retrospective review from January 2007 to 2010, in which 243 tongue carcinoma patients were included. They have seen the contralateral metastasis in around 29% of the patients, out of which 91% of the patient had an ipsilateral node positivity. And they suggested that contralateral node is extremely rare in a negative ipsilateral neck. So if level 1A is positive, then it is advisable to do the contralateral neck dissection and also the lesion crossing midline or reaching up to the midline. Skip skin involvement and ipsilateral nodal metastasis as a predictor of the contralateral node metastasis in buccal mucosa cancer. This was a retrospective study done from 2009 to 2013 in which 125 cases of buccal mucosa GBS lesion reaching or crossing midline were included. The factor predicting contralateral nodal mets were ipsilateral node positivity and skin involvement. They concluded similar that the contralateral node metastasis is rare in absence of ipsilateral nodal metastasis. Then coming to the sentinel lymph node biopsy. Sentinel lymph node biopsy can reliably detect microscopic lymph node metastasis. It offers a potential solution for the management of the N0 neck, but at the present time, it is not widely offered and standardized. It is not the standard of care in early oral and oropharyngeal cancer, at least in India, while the USA and European studies are continuing doing the trial and it is gaining utility there. So the procedure for the sentinel lymph node biopsy are they select very early oral squamous cell carcinoma T1, T2 well lateralized cases in which preoperatively they inject a peritumoral injection of the radiotracer which is 99 technetium or 99 colloid followed by the lymphoscintigraphy scan and SPECT scan. The position of the sentinel lymph node is marked on the skin. They remove the tongue primary tumor and they check the level sentinel lymph node in the neck. After marking the lymph node, they remove the sentinel lymph node using the intraop gamma probe, and then the meticulous histopathological examination of that group is done. Sentinel lymph node concept came for the minimal neck dissection and to avoid the extensive morbidity of the radical neck dissection and also to improve the functional outcome and improve the quality of life of the patient. So this is the diagram which is showing the well lateralized right lateral border of the tongue tumor which was then excised and the gamma probe was used in the neck. The probe which shows highest activity is marked with X and the sentinel lymph node has been removed. The right hand side diagram shows the lymphoscintigraphy scan in which the blue arrow shows the primary tumor where the red arrow shows the lymph node. The light uptake in the SPECT CT scan shows the primary tumor in the right lateral border of the tongue followed by the lymph node in level 1B and level 2 and 3 also. So there are multiple trials has been came up in the last 1 decade on sentinel lymph node biopsy. This is a sentinel European node trial, SENT trial. It is a landmark article published by Class Scaling Group in NHS London. in which they did the prospective observational study of 415 patients of early squamous cell carcinoma, and they found that the sentinel lymph node was undertaken with an average of around 3 nodes removed per patient, and sentinel lymph node was found in 99% of the cases which report its accuracy. Positive sentinel lymph node came in only 23%, while the false negative rate is 14%. The disease specific survival was 94%, with a sensitivity of sentinel lymph node up to 86%, with negative predictive value of 95. So they concluded that the sentinel lymph node biopsy is reliable and a safe oncological technique for staging the clinically N0 NEC in patients with T1, T2 oral cancer. Another landmark trial, which includes Sentinel Marol, which is done study in the 10th center in France, led by Renaud Garel, in which they evaluated sentinel lymph node with the elective neck dissection, and they found no difference in the neck node recurrence-free survival and overall survival between both the groups. Another article published by Hasegawa from the Japan group, they did the similar study like the France group, and they concluded that there is no difference between elective neck dissection and sentinel lymph node group, with sentinel lymph node group provide less morbidity, better functional outcome, less hospital stay. So this is the table which compares the two studies, Garel group, which is a France group, and Hasegawa, which is a Japanese study. The line marked in red is a major one. The isolated neck node recurrence, there is a no difference between both the groups, SLND compared to END in both the studies, and also there is a no difference in overall survival between both the groups in both the studies. So this is a meta-analysis of the 66 studies on sentinel lymph node biopsy, which include more than 3,000 patients, and they found that the pooled sentinel node identification rate was 96% and sensitivity was 87%, with negative predictive value of 94%. There is 6% failure rate, which is comparable to the elective neck dissection. This is an Indian study led by Dr. Shiva from Tata Memorial Group, in which they did the survey among the Indian surgeons treating oral cancer whether they are using sentinel lymph node biopsy on a regular basis or not. They surveyed 350 patients with a response rate of 47%. Most responder says that they were managing neck with the elective neck dissection in a N0 neck. Only 15% of the responders were practicing sentinel lymph node biopsy. And most of the responders believe that the sentinel lymph node biopsy offers better shoulder function. What are the deterrents for not using routine sentinel lymph node biopsy in India? Its additional cost, unavailability of necessary expertise and infrastructure, time consuming, higher false negative rate, and a possible need of a second surgery. So these are the limitations of the sentinel lymph node. It is unreliable in the previously treated neck due to the aberrant lymphatic drainage. It is not useful to detect the soft tissue deposit. There is a shine through phenomena in the floor of the mouth cases and early oral squamous cell carcinoma involving the lip. If the sentinel lymph node come positive, patient may require the second surgery at the same time or at a later time. It is a long learning curve, the cost associated with it, and it requires additional services like nuclear medicine, IHC, and sterile sepsion. So according to the ESCO guidelines published in 2019, what are the recommendations for the neck dissection? For the patient with clinically N0 neck, an ipsilateral elective neck dissection should include level 1A, 1B, 2, and 3. An adequate dissection should include at least 18 lymph nodes. Coming to the concept of a minimal invasive, which is a super selective neck dissection concept given by Carlos Suarez and Alfio Farlito group. Super selective neck dissection has been defined as a complete removal of all the fibrofatty tissue content, including lymph node, along the defined boundaries of one or two contiguous neck dissection. This is very limited neck dissection has been proposed to be oncological sound for two indications, for the elective neck dissection of a clinically negative N0 neck and treatment of persistent neck dissection after chemoradiotherapy. The data from the reviewed study suggests that superselective neck dissection with the use of intraoperative frozen section may achieve regional disease control that is comparable to the more extensive neck dissection in selected group of patients with laryngeal cancer in which there is a removal of level 2 and 3 and oral cavity which are the primary apical and lymph node level 1A and 2 among patients with a clinically negative neck. Coming to the another advancement which is a Da Vinci assisted robotic neck dissection. This was a study published recently in China. This study compares the retroauricular robotic assisted approach using 2 to 3 robotic instruments with conventional open neck dissection in early end stage oral cavity carcinoma. They found that perioperative outcomes, including hospital stay, drain, complication, and lymph node yield, showed no significant difference between both the group, and they concluded that robotic assisted neck dissection via retroauricular route is a safe and effective alternative for early stage oral cavity cancers like carcinoma, preserving oncological outcome while improving cosmetic appearance. So this is a pre-op marking of the patient retroauricular approach where the incision is extend posteriorly with the facelift incision and the retractors are placed and the two instrument can be used bipolar as well as monopolar and sometimes a third instrument progress can be used. The cosmetic and aesthetic functional outcomes were excellent as compared to the neck dissection. There is a hidden scar behind the ear which is barely visible. So in the past 1 decade, there are multiple publications and articles coming on the robotic neck dissection in head and neck cancer all across the globe, which various techniques such as Baba technique, retroauricular technique, or axillary technique. So to summarize my talk, the philosophy of the management of a metastatic disease in the neck has changed considerably over the past few decades, with a better understanding of the pattern of lymph node metastasis, leading to a subclassification of levels and understanding the importance of prognostic factors such as extracapsular spread and perineural invasion. We have able to preserve uninvolved lymphatic and non-lymphatic structure. The improved quality of life and functional outcome have helped guide this evolution. More extensive surgery does not necessarily equate to a better oncological outcome, and less can often mean more. Special techniques such as ultrasound guided needle biopsy, and sentinel lymph node biopsy have a potential to further refine our surgical expertise to eradicate the cancer, preserve function and cosmetic, and maintain excellent oncological outcomes. Thank you.